Thank you for joining me today. My name is Angie Besh, and I am a doctor of physical therapy. I am also the Phoenix Home Health Therapy Consultant, and I'm excited to be here with you today. I have over 10 years of home health experience, so we are going to be learning and diving into the PDGM model and how it's affecting and impacting therapy and our case management. So before we get too far into therapy reimbursement, let's make sure that we are falling back on our Phoenix Home Care mission statement. This is at the heart of what we do every day. So our mission is to offer new beginnings and meaningful opportunities to caregivers and clinicians while providing home care services to our clients built on innovation, skill, and those Christ-like values, patience, honesty, and compassion. So as home health continues to change and evolve, this is what will always set us apart. Let's take a look here at PDGM. That stands for Patient-Driven Groupings Model. And prior to PDGM, we had a system known as PPS that had 60-day billing episodes and therapy service thresholds. The difference here is that we have eliminated therapy thresholds within PDGM. Previously, therapy was the driving factor on resources and reimbursement. So as patients required more therapy, then they also required more resources, right, which drove reimbursement. But now, in PDGM, we have two 30-day pay periods. Still makes up a 60-day episode. We're still doing our OASIS assessments and outcome measures, but we no longer have those thresholds, right? Those therapy thresholds are eliminated. The emphasis now is patient-centered. It's specific clinical characteristics of the patient. If we see this picture here, this color-coded graph, this is PDGM and the 4 key elements that make it up. This is now what drives reimbursement for home health. These are based on things like timing and also coding. What are the primary and secondary diagnosis codes? And then also this green line here, that is going to be our functional impairment level. That is based off of our OASIS assessment. If we do take a closer look at these clinical groupings, we have 12 categories now that our therapy, our primary diagnosis may fall into. Things like neuro rehab or musculoskeletal rehab. There's categories for wounds. There's category here for complex nursing intervention, behavioral health, and then there's one called MMTA. So what is MMTA? Well, that stands for medication management, teaching, and assessment. That is further broken down into categories such as surgical aftercare. We've got cardiac, endocrine, respiratory, GI, GU, infectious disease. So just knowing that we have those clinical groupings, we'll look at this pie graph here and you can see that the large portion of it, this dark piece of the pie, that is our category for MMTA. That is going to contribute to the majority of our caseload. So over here on the bar graphs, you'll see that wounds on the right-hand side, they're going to require more resources, right? Because they need more supplies. We do have neuro rehab right next to that, musculoskeletal rehab, complex nursing. They all will need more resource and therefore more reimbursement. When we look at MMTA, that's second from the left, that's this bar. It's possibly going to be less reimbursement, more focused on education, teaching, assessment. Not as many supplies, not as many therapies may be required here, therefore less reimbursement. What we are going to have to be getting really good at is how do we most effectively and efficiently care for our patients that are in this category. We want to be able to balance the patient's needs against the cost of health care. So this matters to everyone in home care. We want quality, not quantity. Here's the functional scores. I just wanted you to see this slide just to know exactly which 1800 ADL scores were figured into the functional impairment. There are many courses out there that address how to accurately answer each item on the OASIS assessment. However, for today's purposes, I just want you to remember we must answer these questions with safety in mind. A lot of times therapists will answer questions with how they see the patient doing, not entirely based on what is safe for that patient to be doing. And remember, any OASIS answer should correspond with therapy evaluation. There should be some consistency between documentation. So just keep in mind with this case mix, this model, that these 30-day payments, they're designed to cover all 6 of the home health services provided in the Medicare Part A benefit. That includes our skilled nursing, PT, OT, ST, our social work, and home health aid services. This does not mean that the patient will receive all 6 services, but we must understand the reimbursement here is not solely for nursing and not solely for therapy, social work, or aid services. Even though some of those categories say rehab or say nursing, we have to find the best mix of disciplines for each of those categories. So we need to ask ourselves, what is the best mix, and how do we determine the intensity of each service to best meet the needs of the patient? What does CMS say? With this new model taking out therapy thresholds, what they've decided is that they're really shifting from a volume-based therapy model to more of a value-based therapy model. What they are saying is, even though we've changed the way that we are repaying for home health, the need for therapy services under PDGM remains unchanged. So they still say these patients need therapy, but any of the therapy that is provided needs to be determined by the individual needs of the patient. So we're not restricting any of their therapy. We're not putting a number on the frequency or duration of visits. We're simply just determining what they need on an individual basis. So really trying to build that culture of value. How do we make each visit count? We really want to focus on giving the patient exactly what they need, not one visit more, not one visit less. So what do we fall back on? What is skilled, reasonable, and necessary? Our skill, that is what we went to school for, right? That is what we bring into the home when we treat patients. That is what leaves with us when we leave the patient's home. That is something that's inherent in us. That is our skill. Reasonable simply means it's not excessive. It's not extreme. And necessary begs that question of why you, why now? Is it absolutely essential for the desired outcomes? If you say that visit is necessary, then yes, it should be absolutely essential for those desired outcomes. But does that show in your documentation? Therapists tend to oversimplify in their documentation. So we understand that we do prescribe individualized exercise programs, right? We do educate on positioning, range of motion, substitution, those safe techniques in the home. We monitor the patient, we monitor the program, we're constantly changing, modifying, progressing the plan, but here's what we document, here's the problem. Again, we're just documenting what we're seeing. Maybe this patient did 3 sets of 10 toe tapping and seated marching. That's okay, right? But why? This patient ambulated 30 feet twice, standby assist. They started on some yellow TheraBand and they used that resistance for all the exercises and all the planes. Not very specific, maybe a little too general, not necessarily showing that the therapist is intervening. Where did the therapist stop to disrupt? And where did the therapist teach and provide that education? Where's that skill? So right now this is just showing me what the patient did, but what did the therapist do? That's where we need to get to. We need to be a lot more specific and detailed in our documentation. How do we paint the picture for someone like CMS or external auditors that might be looking at our charts. Are we capturing details inherent to the patient? Are we looking at their disease process, their knowledge deficits related to that disease process? What's their functional mobility, their safety awareness? What about those external factors? What's their support system? What's their caregiver situation? What equipment do they have in the home? What does the environment look like? We just want to make sure that we're painting that picture and we're trying to get to the specific need for that individual patient. And that leads us to defensible documentation. This is where each visit will be able to stand alone. This is where you have the detailed homebound status. You've got that subjective statement in there. That patient is part of that visit. Those objective tests and measures. Maybe there's an assessment. This could happen on even a regular visit. What is your professional opinion that day? What is the plan? What about discharge planning? We have to think about discharge planning from day one. And does that show in the care coordination? So let's take a look here at homebound status. We're all familiar with criteria 1 and criteria 2. The problem is sometimes we can just check some boxes and move along and not lend any detail or any specifics to the homebound status. Typically in criteria 1, they're meeting the top bullet point here. They have an illness or injury. They need supportive devices. Maybe it's a wheelchair. Maybe it's a walker. Maybe they need assistance of another person. Criteria 2 is the one that often we repeat back, right? It's considerable and taxing effort for the patient to leave home. They have a normal inability to leave, but simply repeating that back doesn't necessarily mean that they're homebound. So what are the details? What can you specifically point out that shows what is their gait deterioration after a certain amount of feet, or what is their specific fall risk and what test shows that? Or maybe they have a drop in their oxygen saturation after 82 feet. Be specific. Maybe the normal inability here is thinking about their prior level of function. Their regular ability to leave home was limited even prior and only for medical appointments. So one other question you might ask yourself here is, why not outpatient therapy? Why can't that patient perform ADLs that day and prepare for an outpatient visit, exit the home, perform a car transfer, travel to the clinic, have to get out of the car, enter, walk into the clinic, and then even have to stay there for another hour and participate in an outpatient therapy visit. And then reverse that. They've got to come home. So now, once they're home, how do they feel? Are they exhausted? Do they have to lay down and take a nap for 4 hours? Are they taking pain pills? So what's the result of them leaving the home? Paint that picture of taxing effort. If we look at subjective here, then we see that the patient is giving you their feedback. So we want to know what is working. What did the patient tell you is or is not working? Are they telling you they're willing to participate further? Do they agree to this plan of care? What is a significant event that may have occurred? So sometimes we just simply put no pain or doing well, but we want to dive in here and make sure that the patient, if they're telling you something that was successful, then go ahead and document that. That is going to help justify the need for therapy. If we look at objective data, this is your quantifiable test and measures, right? This is, for example, maybe a Berg balance test, a 30-second chair stand test, a 2-minute step test, gait velocity test, Barthel index, and Montreal cognitive assessment test. This is our therapy toolbox. Are we using the right tools? I always kind of think of that example of that plumber that walks into your house and he only has one wrench. Is that very skilled? Do you really need a plumber if he only has one wrench? So if all of your visits and all of your therapy home exercise programs look the same, is that very skilled? That'll beg the question of, is that reasonable and necessary? So here we have the opportunity to have more tools, more wrenches, you could say, in our toolbox. Are we picking the best one? Are we picking the best instrument that quantifies the patient's impairment? We need to practice at the highest level of our license, and we need to be familiar with all of these tests and measures. At the end of the slide today, I will have some resources for you that will build on your therapy toolbox. Here, if we're looking at assessment, we are wanting to know the situation, the background, the recommendation here. What's your professional opinion? So it might read something like, patient's a 78-year-old female who was recently hospitalized due to a left hip fracture, status post-open reduction internal fixation on 6/20/21. The patient discharged directly home to the care of her spouse, and he is available around the clock. Patient has a past medical history of diabetes, hypertension, and falls. This patient previously was independent in her home with the use of a cane, and she utilized it intermittently. Patient currently presents as a high fall risk, and this is evidenced by her gait velocity test and her 30-second chair stand test. Patient demonstrates an antalgic gait pattern, and she requires a rolling walker and min assist for safety right now. So in my professional opinion, this patient will benefit from skilled therapy. We're going to focus on transfer, gait, and balance training to try to achieve that optimal function in her home. We're going to try to return to that use of a cane. So don't forget here, I put a note in on reassessments. We must compare and contrast from the evaluation to that reassessment visit. And we can compare and contrast scores at any time. It doesn't have to be on reassessments. You could do it on progress notes too. You know, assistants may not be interpreting that, but they can definitely score that. But definitely think about comparing and contrasting. What is the big picture? Does your reassessment stand alone? Does that visit note stand alone? If I look at that, can I see that there's a change in that score? That's what we're looking for. How are we making a difference? And how are we making it meaningful? So we definitely need to have specific and relevant goals for patients. We know that there's this SMART acronym for goal setting. It's specific, it's measurable, attainable, relevant, and it's time-bound. We do pretty good with most of those pieces of the puzzle. Sometimes may not be relevant to the patient. We might think it is, but maybe not to them. Maybe it's not specific enough to the patient. Maybe all of the goals look the same on your care plans. Here's just an example just to get you thinking about something that might be more specific and relevant when you're writing goals. This patient will demonstrate 30% improvement in lower extremity strength as evidenced by a 30-second chair stand test score within normal limits. So for this age and gender, the normal would be 10 repetitions. That way this patient can resume ascending and descending the 12 steps in the home. That's pretty specific. And they can access the bedroom and the bathroom on the second level of the home within 5 weeks. So that becomes relevant to them. They want to get to their bedroom and bathroom. So if we write goals like this, maybe we only need 2 or 3 because look, we're already addressing lower extremity strength. There's gait and step training in there. Maybe we don't need all 12 of those prescripted goals that oftentimes get put in. And we don't always have to write a goal for an HEP. So if we can make it more specific and more relevant to the patient, then that is going to get us a lot farther on defensible documentation. And sometimes I should point out here, our goals may not always be to reach independence. Sometimes we're just reaching, we're educating, we're teaching, and trying to reach optimal function. There might be a max potential that we need. Within the PDGM model, we need to ensure that we are implementing the right service at the right time, at the right intensity. So this means why you, why now? What service is going to take the lead? You know, what service is going to reinforce education to decrease that rehospitalization risk? What is the intensity of each service? This is where we put on our case manager hats. So I like to go into a few examples. I learned the best just by talking through specific case examples. This first one here, we could think about a patient who's just come home after CHF, exacerbation, and a hospitalization. So every discipline needs to ask themselves this question, you know, what am I going to do today to decrease that risk of my patient going back into the hospital? So when I'm looking at that plan of care, I'm looking at those goals, I'm walking in that house, maybe skilled nursing is going to educate on medications and also that diet restriction that goes along with it. They're going to be educating on daily weights. But hold on a minute, PT can also reinforce that. And if we need to be getting daily weights, how is that patient getting to the scale? How are they getting up out of the chair? How are they walking across the room to the scale? How are they stepping up on it? How are they balancing on it? So are they really weighing themselves every day? And if this is something they need to do every day, then does this not become an activity of daily living? Something that OT can come in and talk about energy conservation and reinforce teachings alongside their ADL training. So just something to kind of put your thinking cap on and how we can all work together. Now, what about this example? We have someone who's had a new CVA. Maybe this patient was independent prior to the CVA, and now they have one-sided weakness. They have one-sided hemianopsia. They have neglect. They're not wanting to get out of bed, or they can't get out of bed without assistance. Poor activity tolerance, and now all of a sudden they have a nursing assessment and therapy assessments, and everybody is wanting to come in twice a week, and the patient might be a little overwhelmed. Maybe that patient just wants to focus on bathing at first, or medications to make sure that they understand. Maybe we consider that one therapy has a greater intensity up front than another. Maybe that patient wants to focus on OT, and we might consider putting PT on hold and reassessing. Maybe that patient will be able to better tolerate multiple therapies down the road. They'll probably be having speech therapy as well. Is there an opportunity here to consider staggering the disciplines upon the start of care if necessary? If that's what's right for this patient, then let's consider it. How about that patient with wound care or fracture now we have a weight-bearing restriction. So does this need to be, in my head, I'm thinking, we have a weight-bearing restriction, maybe we need to make this evaluation only. Maybe we do the teaching on the weight-bearing restriction and we teach on an HEP, but we come back at a later date, maybe when this wound is healed or this fracture is at a point where the doctor's allowing weight-bearing, we can start progressing into those pre-gait activities. How about dementia? This one can be kind of tough. Can we document that the patient is following directions or that they're retaining information? Do we have any cognitive assessments that support this? Are they remembering what we're teaching them? Because if there is carryover, then that's great. But if there's not, then we probably need to shift our focus to caregiver education now. And do we really need to be in there time and time again when the caregiver is verbalizing and returning demonstration? No, we probably need to discharge to caregiver education, to an HEP, possibly to max potential. We can always reevaluate if we need to down the line, but once we have our goal met, we need to discharge. How about that total knee that just came home from the hospital? He was in a lot of pain, reduced range of motion, a lot of swelling. So we put him on 3 times a week for 3 weeks. But this guy previously was golfing, and he's recovering a little faster than others. And he's starting to get tired of his 4 walls, and he's wanting to walk outside a little bit, practice steps. After a couple weeks, he got a good report from his doctor. He's looking to transition to a cane. This one sounds like he might be ready for outpatient. So definitely, can we change our plan of care? Absolutely. And we want our assistants to be talking to their supervising therapist, letting them know that this patient is ready to go to outpatient therapy. So we can be updating that. We can be getting them to the right service at the right time. What about a missed visit? I always say a missed visit could be a missed opportunity. If we said that visit was reasonable and necessary and now we've missed it, how was that patient impacted due to that missed visit? Was there a setback? Can you document that something happened or missed or setback due to you not being there that day because you said it was necessary, right? You said you absolutely needed to be there for those outcomes to be met. But what if they made progress despite that missed visit? Well, then that doesn't show that that visit was necessary. Maybe we need to put our thinking caps back on and say, do we adjust this plan of care? So can we change the plan of care? Absolutely. Yes, we want to change the plan of care as often as we need to, right? It shows skill. It shows that we are thinking about this patient. It shows we are critically thinking and we're using our clinical decision-making skills. It is skilled. We're modifying the plan of care. We're updating goals. That's ensuring, we're thinking about all the reasonable and necessary services that we can offer. Are we taking care of this patient at the right time, at the right intensity? We want to try to avoid those patients that were on autopilot. Maybe they come on services and their therapy goes along without any problems, and all of a sudden on discharge they've met all their goals. Do we show in our documentation where it was skilled, where it was reasonable and necessary? Just making sure that we don't have a care plan on autopilot, right? We want to keep updating it, keep changing it. In summary, we really do not want any cookie cutter care plans. One size does not fit all. So I challenge you here, just look back at your last 5 care plans when you're considering these questions. First one here, do you tend to use the same frequency and duration? So I know we can all get pretty comfortable with twice a week for 4 weeks, but when we start to see that repetition happen over and over and over, is it reasonable and is it necessary? What about the test and measures? Do you happen to use the same test and measures every assessment? Does your wording throughout the assessment look the same? Can you identify, if you just looked at their goals, if you picked out just the goals on that care plan, could you identify which patient that goal belonged to? Was it specific to that patient? Was it relevant to that patient? And what if you looked across the board at the different disciplines, the different therapies? Does it show consistency? Does it show care coordination? Or does one therapy say they're independent and another one say they're min assist? Does it flow? Are we painting the picture? And I just put in a note here to reconsider things that might not be specific. Could be things like household or community distances or that least restrictive assisted device. Those tend to fall in that category of, is it really that specific? Do you really know what the plan is? Do you have a plan, or are you just writing a vague goal to capture whatever that patient decides they can do? If we know we want them to go a certain distance, let's say exactly how many feet, and guess what? It doesn't have to end in a 0 or a 5. We don't have to use even numbers. If we know it's 82 feet to the bathroom, let's write the goal for 82 feet. And once we've met that goal, let's discharge. So all this can be hard to wrap our head around at first, but think about this. Yes, PDGM changes the role of therapy and reimbursement, but this may be an opportunity for growth. This could be within and amongst the home health team. I look at it as an opportunity to work together as a team. We start to work together to begin care planning, making it more individualized to that patient, and we're working among all the disciplines. One reason people resist change is because they may focus on what they have to give up instead of what they have to gain. So let's hope that this is something that we can gain, we can work together. This is an opportunity. Here's my resources I promised you. We do have some really good ones on the rehab measures in the NIH toolkit for your toolbox, but anyone who's in home health really does need to read Medicare Benefit Policy Manual Chapter 7. Be familiar with that. Make sure that you are reading that and you are understanding that. APTA also has a home health section that can be helpful. You can check out those resources. You can also email me if you have questions. Here's my email. It's abesh@phoenixhomehc.com. I'm happy to answer any questions. So really want to thank everyone for being here and spending time and watching this presentation. I want to encourage everyone to just continue to provide that excellent therapy that we always have. Send me your questions. I may even challenge you here. Just send me some examples, some case management examples going forward in the next few weeks where you come across a case where you coordinated with other disciplines, or maybe you changed your thinking on how you were going to plan your intensity or your frequency for that patient. Maybe how you tried a new test and measure, or you made your goal more specific. Even the assistants, please share, how you coordinated with your supervising therapist, how you helped to update the care plan and update the goals. So I'm looking forward to meeting all of you and traveling and meeting the teams in the next upcoming weeks. And I'll be happy if I start to get some emails and some case management examples come in my way, I will share those with all of you, and that way we can learn together, we can grow together, and this will be an opportunity to wrap our heads around all of this information. So once again, thank you for your time, and I hope you all have a great day.